In this session, we will be discussing about three key questions. First, what is a study design and how can epidemiologic study designs be classified? Second, how do descriptive, randomized, and non-randomized analytic study designs work? Third, how can researchers compare different study designs and choose the most suitable design for a research question? An epidemiologic study usually begins with a research question. After the research question is clearly stated, the next step is to choose a study design that can answer the question. A study design is a plan for selecting study subjects and obtaining data about them. In practice, most epidemiologic research uses a smaller number of standard designs. These standard designs are flexible enough to answer many different research questions. Study designs can be divided into two main groups: descriptive studies and analytic studies. Descriptive studies describe a disease or health condition. They may show how common it is and how it differs by person, place, and time. These studies usually do not start with a specific hypothesis about cause. Analytic studies, in contrast, test a specific hypothesis. In epidemiology, this often means asking whether an exposure affects the risk of an outcome. To categorize an analytic study, the first question is, did the investigator assign the exposure? If yes, the study is an experimental study. We then ask whether the exposure or intervention was assigned using random allocation. If participants were randomly allocated, it is a randomized controlled trial. If allocation was not random, it is a non-randomized controlled trial. If the investigator did not assign the exposure, the study is observational. We then ask whether there is a comparison group. If there is no comparison group, the study is mainly descriptive. If there is a comparison group, it is an analytical observational study. For analytical observational studies, the next question is about the direction of inquiry. If we begin with an exposure and then look for the outcome, the design is a cohort study. If we begin with the outcome and then look backward to determine previous exposure, the design is a case-controlled study. Finally, if exposure and outcome are measured at the same time, the design is a cross-sectional study. First, let's start with the descriptive studies. A descriptive study is conducted without a specific hypothesis. Descriptive studies may identify new health problems, describe their clinical features, measure their frequency, and show how they vary across people, places, or time. A case report describes one notable clinical event. The event may involve an unusual combination of signs and symptoms, an unexpected experience with a treatment, or a sequence of events that suggests a possible causal relationship. A case report can alert other health professionals to watch for similar events. It can also lead to later studies that measure the size of the problem or test a possible association. A classic example of a case report is Alois Alzheimer's description of a 51-year-old woman with progressive memory loss, disorientation, and behavioral changes. After her death, Alzheimer found brain abnormalities. This disease was later known as Alzheimer's disease. There are distinct strengths and limitations of case reports. One strength is that a case report may provide the first indication of a new disease, unusual problem, or possible association. It can also lead researchers to investigate the finding using stronger study designs. However, case reports also have limitations. They often begin by serendipity, meaning that a clinician notices something unusual by chance. Because of this, they may not be based on a fully planned study design. So case reports are useful for giving an early signal, but stronger studies are needed to confirm the finding. A case series shows that an event occurred repeatedly. A case series allows researchers to identify features shared by several cases. It also allows them to describe differences among the cases. Now, let's look at an example involving avian influenza in Indonesia. Between 2005 and 2008, Indonesia reported many cases of avian influenza A, H5N1. Researchers described 127 patients who met the WHO case definition. 93% developed fever within the first 2 days. However, common flu symptoms such as cough, runny nose, and muscle pain were less frequent. As the illness progressed, many patients developed serious respiratory problems. The disease was very severe. 103 of 127 patients died, giving a case fatality proportion of 81%. Delayed antiviral treatment was associated with a higher risk of death. This is a case series because researchers describe the clinical features and outcomes of a group of patients with the same disease without a comparison group. Case series studies are usually simple, quick, and inexpensive. They are useful for describing new, rare, or unusual diseases, including their clinical features, treatment, and outcomes. They can identify new patterns or adverse effects and generate hypotheses for future research. However, case series have no comparison group, so they cannot establish cause and effect. They usually cannot measure incidence or risk because the population at risk is unknown. Selection bias and confounding may also affect the findings. A descriptive study based on rates combines cases with information about the population. First, researchers count the cases. Second, they define the population that produced those cases. This population provides the denominator. Third, they use this information to calculate disease frequency, such as incidence, prevalence, or mortality. Finally, they can compare disease frequency by person, place, and time. The findings are usually exploratory and can help generate hypotheses for future analytic studies. This example shows how a descriptive study based on rates can help us understand the burden and pattern of disease in a population. In this study, invasive MRSA was monitored across 9 metropolitan areas covering about 15 million people. MRSA stands for methicillin-resistant Staphylococcus aureus. It is a type of Staphylococcus aureus bacteria that has become resistant to several commonly used antibiotics, including methicillin and related antibiotics. Over 4 years, the study identified 21,503 cases, and about 72% were likely acquired in hospitals. The incidence of MRSA varied greatly by age. Rates were also higher among males and African American people. Importantly, the overall incidence decreased from 3.21 to 2.63 cases per 10,000 person years. This decline may have been related to prevention programs. Descriptive studies based on rates have some important strengths. First, they help us understand the burden of disease in a population, for example, by showing how common a disease is. Second, they allow us to compare disease patterns by person, place, and time. These patterns can help researchers identify important differences and trends. Third, these studies are useful for generating hypotheses that can be tested in later studies. However, they also have limitations because they are descriptive. They cannot establish a cause and effect relationship. They also may not always allow us to calculate individual risk, especially when detailed population information is not available. In addition, other factors, called confounders, may influence the patterns that we observe. An analytic study is designed to test a hypothesis. The main question is often, does a particular exposure cause a particular outcome? Here, exposure is a broad term. It may be a personal characteristic, a behavior, an environmental factor, a treatment, a social condition, or any other factor that may influence health. Exposure may also be called a risk factor, putative cause, independent variable, or predictor. The outcome is what happens in relation to that exposure. In studies of disease causation, the outcome is usually the occurrence of disease, but it may also be survival, disability, recovery, or quality of life. Other terms for outcome include endpoint, response, and dependent variable. Clearly identifying the main exposure and the main outcome helps researchers choose the most appropriate study design. A randomized trial is an analytic study that uses a formal process to create an intervention group and a control group. Researchers start with a source population and identify people who are eligible for the study. Eligible participants are then asked for informed consent. Those who agree to participate are randomly assigned to either the experimental group or the control group. The experimental group receives the intervention being studied. while the control group receives no intervention, a placebo, an alternative treatment, or usual care. Researchers then follow both groups over time and measure their outcomes. Finally, researchers compare the outcomes between the two groups to see whether the intervention made a difference. Randomization makes a randomized trial stronger for causal inference because it provides strong protection against confounding. Researchers assign participants to groups by chance rather than based on their characteristics. Because of this, the intervention and control groups are expected to be similar, on average, in both measured and unmeasured factors. Therefore, if the two groups have different outcomes at the end of the study, researchers can be more confident that the difference is due to the intervention rather than other factors. This is why, when other conditions are equal, randomized trials provide a stronger basis for causal inference than many other study designs. For example, a randomized trial in central England tested a program to prevent repeated falls among adults aged 60 years or older. Emergency medical staff screened 252 people who had experienced a fall, called an ambulance, but did not need hospital transport. Of these, 230 were eligible and 204 agreed to participate. The participants were randomly assigned to two equal groups, an experimental group and a control group. The experimental group received a fall prevention program that included balance and strength exercises, changes in the home to remove tripping hazards and install grab bars, a medical review to prevent overmedication and control blood pressure, and group sessions about fall prevention. The control group continued to use their usual social and medical services. All participants recorded their falls in a diary and sent a summary every month. During the following year, the fall rate was 3.4 falls per person year in the experimental group, compared with 7.6 falls per person year in the control group. Ambulance calls related to falls were also 40% lower in the experimental group, and several measures of physical health improved. The study showed that the fall prevention program was effective in reducing falls among older adults. Randomized trials have several important strengths, but they also have some limitations. One major strength is that randomization helps control both known and unknown confounding factors, so the groups are more comparable. Because of this, if there is a large difference in outcomes between the groups, we can more confidently attribute that difference to the exposure or intervention. Randomized trials also allow us to directly measure incidence by following participants over time, and they can compare several different outcomes between the groups. However, randomized trials are not always possible. Some exposures cannot be changed or assigned by researchers, and some assignments may be unethical or impractical. Randomized trials are also less efficient for studying very rare outcomes because they may require a very large number of participants. Similarly, if an outcome takes many years to develop, the trial may need a long follow-up period, making it expensive and time-consuming. A quasi-experiment is an intervention study that does not use randomization. The researcher still decides who receives the intervention and who receives the control condition, but participants or groups are assigned using a non-random method. Quasi-experiments are useful when randomization is not possible because of cost, practical difficulties, logistics, or political reasons. So the study may look similar to a randomized trial, but the main difference is that the groups are not assigned randomly. For example, the Living for Life study tested a school-based program to prevent obesity among adolescents in New Zealand. 6 schools took part. 4 schools received the Living for Life program, while 2 similar schools served as controls. The schools were assigned based on their geographic location rather than randomly, so this was a quasi-experimental study. The intervention included youth-led activities, exercise, changes to the school food environment, and other activities to encourage healthier behavior. The control schools were located away from the intervention schools to reduce spillover of the program. After 3 years, obesity prevalence increased from 32% to 35% in the intervention schools and from 29% to 30% in the control schools. Overall, the program did not produce meaningful changes in eating or exercise behavior. A cohort study is an observational study in which a group of people is classified according to their exposure and followed over time to see who develops a particular outcome. As shown in the flowchart, the study begins with a cohort of healthy subjects. First, the researchers identify the exposure groups by separating participants into exposed and non-exposed subjects. Second, they follow both groups over time or reconstruct their follow-up using past records. Third, they measure new outcomes by identifying who develops the condition and who does not in each group. Finally, they calculate and compare the incidence of the condition in the exposed and non-exposed groups. This comparison helps determine whether the condition occurs more frequently in one exposure group than in the other. For example, in this oral contraceptive cohort study, about 47,000 women were recruited. About half were current users of oral contraceptives, while the other half had never used them. Their physicians updated information on contraceptive use and illnesses twice each year, and active follow-up continued for 28 years, with cancer follow-up continuing through population registries. Importantly, exposure status could change when women who had never used oral contraceptives started using them, so person time rates were used to account for these changing exposure groups. The researchers then compared cancer incidence between the groups, with rates adjusted for age, parity, smoking, and social class. The relative incidence was 1.3 for cervical cancer, 0.5 for uterine body cancer, 0.5 for ovarian cancer, and 0.9 for breast cancer. The study found lower risks of uterine body and ovarian cancer with oral contraceptive use. This example shows the key structure of a cohort study. Identify exposure groups, follow them over time, measure new outcomes, and compare incidence between the groups. Cohort studies have two major subtypes, prospective and retrospective. The main difference is when the outcomes occur in relation to the calendar time when the study begins. In a prospective cohort study, the study begins before the outcomes of interest have occurred. The researchers first form the exposed and non-exposed groups. They then follow both groups into the future. Some participants develop the outcome, and some do not. In a retrospective cohort study, the exposures and outcomes have already occurred when the research begins. The researcher reconstructs a cohort study using existing records. The basic structure remains the same. The researcher first identifies exposed and non-exposed groups in the past. The researcher then uses records to determine which members of each group developed the outcome. A retrospective cohort study uses records that already exist to study past exposures and later outcomes. For example, researchers studied whether statin use was associated with a lower risk of hip fracture. Statins are medicines used to lower cholesterol and prevent heart disease, but animal studies suggested that they might also protect against bone loss. Researchers used existing records from the Tennessee Medicaid program from 1989 to 1998. They compared three groups: 12,506 statin users, 4,798 users of other cholesterol-lowering medicines, and 17,280 people who used neither medicine. Hospital records were then used to identify hip fractures. The hip fracture rate was 2 per 1,000 person years in statin users, 1.8 in users of other cholesterol-lowering medicines, and 3.6 in non-users. These findings suggested that cholesterol-lowering medicines might reduce the risk of hip fracture. However, the lower risk might also have been related to characteristics of people who needed cholesterol treatment rather than the medicines themselves. An advantage of this retrospective cohort study was that up to 10 years of follow-up could be studied quickly because the records already existed. However, an important limitation was that the records were originally collected for other purposes and had little information about possible confounding factors, such as smoking and obesity. Cohort studies have several important strengths. They allow researchers to directly measure incidence because participants are followed over time to see who develops the outcome. They also usually establish temporality. meaning we can show that the exposure occurred before the outcome. Another advantage is that we can study several different outcomes from the same exposure. Cohort studies are also useful for rare exposures, especially when researchers can identify a large group of exposed people. However, cohort studies also have limitations. They may require a very large number of participants, especially when the outcome is uncommon. Participants may need to be followed for a long period of time, and prospective cohort studies can therefore become slow and expensive. A case-controlled study compares the frequency of a past exposure between two groups. Cases are people who developed the disease or outcome. Controls are people who did not develop the outcome. Controls estimate how common the past exposure might have been among the cases if those people had not developed the outcome. For example, a case-controlled study examined statin use and hip fracture in New Jersey. During 4.5 years, 1,222 people were hospitalized for hip fracture. These people were classified as cases. For each case, the date of hospitalization for hip fracture was defined as the index date. The study also selected 4,888 people from the same healthcare program who had not experienced hip fracture. These people were classified as controls. The controls were selected so that the control group was similar to the case group in age and gender. Computerized prescription records were used to determine whether each case and control had used a statin or a non-statin cholesterol-lowering medicine before the index date. Among the cases, 2.2% had used a statin during the 180 days before the index date. Among the controls, 4.4% had used a statin during the same period. A non-statin cholesterol-lowering medicine had been used by 1.4% of the cases and 1.7% of the controls. The researchers then estimated the association using odds ratio that came out to be 0.4, indicating protective effect of statin on hip fracture. Case-controlled studies do not directly measure incidence because participants are selected according to their outcome status. To calculate incidence, we need to begin with a defined population at risk, follow that population over a specified period, and count the new cases that occur. In a case-controlled study, however, the researcher first selects cases who already have the outcome and controls who do not have the outcome. The number of cases and controls is therefore determined by the study design rather than by the actual frequency of disease in the source population. Because we do not have the complete population at risk as a denominator, we cannot directly calculate incidence or risk. Case-controlled studies have several important strengths and limitations. One major strength is that researchers can search for cases or people who already have the disease across a large population or over a long period of time. They only need to collect detailed exposure information from the cases and a sample of people without the disease called controls. Case-control studies are also useful because researchers can examine several possible exposures for one outcome. Another advantage is that they are especially useful for diseases that take a long time to develop because the study can begin after the exposure to outcome period has already passed. The main limitation is recall bias. Because cases already know that they have the disease, they may think more carefully about their past and search for possible causes. As a result, they may remember and report past exposures more completely than controls. Controls may forget exposures because they have less reason to think about them. Cases may also deny or underreport socially undesirable exposures, such as certain behaviors. When cases and controls systematically remember or report past exposures differently, this is called recall bias, and it can make the association between an exposure and disease appear stronger or weaker than it really is. A cross-sectional study measures exposure and outcome at the same point in time or during the same short period. The exposure and outcome are therefore measured together. This design is different from a cohort study, where exposure is identified before the outcome occurs. It is also different from a case-control study, where only exposures that occurred before the outcome are examined. For example, a cross-sectional study examined television viewing and body mass index among 2,368 children aged 12 to 19 years. The participants had taken part in the National Health and Nutrition Examination Survey. During one examination session, each child answered standardized questions about the usual amount of television watched. The researchers also measured height, weight, and other anthropometric characteristics. Adolescents who reported watching television for 2 or more hours each day were significantly more likely to be overweight or obese than adolescents who reported watching television for less than 2 hours each day. The study found an association between obesity and greater television viewing. However, it was not designed to determine which came first. Long periods of physical inactivity while watching television might have contributed to obesity. Alternatively, obesity might have made a teenager less willing to exercise and more likely to watch television. Uncertainty about the direction of causality is a common limitation of cross-sectional studies. However, in some situations, the causal direction can reasonably point only one way. For example, if a cross-sectional study found an association between a genetic marker and a disease, it would not be reasonable to suggest that the disease caused the genetic marker to appear or disappear. Cross-sectional studies identify prevalent cases rather than incident cases. Prevalent cases are people who already have the disease at the time of measurement. The sample may therefore include more people with long-lasting disease. An association found in a cross-sectional study may reflect an association with disease duration rather than with disease incidence. Cross-sectional studies have several strengths. They are usually quick, simple, and relatively inexpensive because researchers collect information at one point in time and do not need to follow participants into the future. They are especially useful for measuring prevalence or how common a disease or condition is in a population. Researchers can also study multiple exposures and multiple outcomes at the same time, which makes these studies useful for understanding health problems and planning health services. However, cross-sectional studies also have important limitations. Because the exposure and outcome are measured at the same time, it is often difficult to know which came first. This problem is called lack of temporality, and it makes it difficult to establish a cause and effect relationship. Cross-sectional studies are also less useful for rare diseases or conditions of short duration, and they may be affected by survival bias because people who live longer with a disease are more likely to be included in the study. A study design is the plan researchers use to select participants and collect data. Study designs are mainly divided into descriptive and analytic studies. Descriptive studies include case reports, case series, and studies based on rates. Analytic studies include randomized trials, quasi-experiments, cohort studies, case control studies, cross-sectional studies, and other specialized designs. The best study design depends on the research question, whether the exposure can be controlled, the available data, how common the exposure and outcome are, the required sample size, and statistical power, and practical issues such as feasibility and cost.